Today we have a lunch break, but it's not a break for all since we're digging into some more weighty issues here around reimbursement and reporting. So with that, we'd like to bring our clinical advisors back. Delphine and Paul, please join us once again in our discussion. And I'm going to be joined by my colleague from Blue Path Health, Robbie Franceschini. We out in California have spent a lot of time working with our state Medicaid. We appreciate Medi-Cal and working with us to really better understand and incorporate eConsult into the Medi-Cal provider manual in California. And we also want to give a big shout out to Department of Managed Healthcare in California for their ongoing support and sitting down and really discussing the issues in great detail. So we appreciate our state agencies' support, and we know that across other states we're starting to have a lot more interest in determining how to measure and report telehealth. So thanks to those of you who are joining us today who might be new to these issues. With that, I'm going to hand off to Robbie, and I know Carol Yarborough, who is new to our panel here, who is Business Operations Manager at UCSF, will be joining us momentarily. But I'm going to start off with just a general question with a couple of large systems represented here, Delphine representing San Francisco and Paul representing Los Angeles. Maybe you could give us just your quick take on what you think the biggest challenge in reporting eConsult encounters has been. It doesn't have to be just with your system, but just over the different systems you've supported throughout the state. What do you think the biggest challenge has been? And I'll send it to Paul first.
So with regards to reporting, I think one of the challenges in our context, at least, is that eConsult is only one of several pathways into specialty care, and it is the primary pathway for non-urgent, non-emergent specialty care. And so we're able to see that pretty well with the data tools in our eConsult platform, and that's fairly well known. But because there is a whole host of specialty care that is coming from other settings, whether it's the inpatient discharges needing specialty care appointments, or whether it's someone interacting urgently or emergently in our emergency rooms or urgent cares, and they need specialty care. It's sometimes challenging to get your arms around all that. And we have a unified electronic health record, but even that sometimes is difficult to pull the right data out of to answer all the right questions, and so really trying to marry those different things, trying to understand where things are coming from. We have over 200 federally qualified health center clinic sites that are also on our system, and so understanding that intake and reporting out on that, and then trying to report on some of those new questions that you're trying to answer. We're pretty good at knowing volumes and specialties, and whether or not it was dispositioned for care, continuing care by the PCP, or whether it was dispositioned to go somewhere else in our system. But knowing a lot of the answers to a lot of those other questions, how did the PCP perceive the interaction? What was the patient's experience? A lot of that is very hard to capture, as we just discussed in our last section.
Yeah, I'll piggyback off of that and actually ask Libby, when you say reporting, I think I'm not entirely clear, because I think capturing the data, because these are all electronic systems, whether it's a software vendor-based system or whether it's embedded in the EHR, I think reporting the data or capturing the data should not be too difficult. It is sometimes challenging, having tried to capture data from our own EHR. I know it's easier said than done, but I think it's clearly doable because of the electronic nature of the communication. I think the more challenging piece is what to do with those data once we have them, right? And I think that's the piece we're working with our state partners for reimbursement, for policy, for understanding its impact on the quadruple aim, right, is really, I think, the key step.
And Delphine, you can see I just shared our screen of a couple of metrics that you and Paul are very familiar with. And Delphine, I don't know if you can just speak quickly. I know that this is a California-focused couple of metrics, but they are applicable to all users of eConsult. So could you just speak to these quickly, Delphine, just how you see these metrics being important in how we look at eConsult's impact on specialty care?
Yeah, absolutely. So I think the first one is the turnaround time, which is what we consider as essentially access to specialty care expertise. So it's the time elapsed between the submission of the eConsult and sending it to your specialist colleagues and your specialist reply. Whether that's a local specialist or an external specialist, it's just the reply with specialty care expertise. And that quick, in California, with our Medicaid waiver, with our Prime waiver, Paul and I have really pushed to have that benchmark be within 5 calendar days, that response time. And so that to us really implies that you have fairly quick responses, fairly quick turnaround, fairly quick understanding of what are the next steps for your patient, whether that is ongoing management, diagnostics, and primary care, whether that's an urgent face-to-face and specialty care, whether that's a referral to a completely different specialist, because perhaps that referral is being sent in the wrong pathway. So really that quick turnaround time is I think the easiest way to capture the benefit, kind of in terms of low-hanging fruit for an eConsult. Thereafter, I think the second metric we have there is the percent of specialty care, or essentially specialty care expertise requests being managed by a non-face-to-face specialty encounter. I think the challenge with this, as we have identified previously, is that there is no target right now, right? We don't know what the target should be, but I think the concept of providing population health by our specialists and specialty care population health is really important, and we need to know where we are before we set benchmarks or targets if that is something we want to do. And we need to recognize that this is going to be different for different services, right, and different specialties, and it's going to be different based on your patient population and your PCP comfort level. One PCP may send an eConsult, which another PCP won't, because of their experience, because of their comfort level with that diagnosis. So again, I think the second one is key to capture, for us to understand what's happening and for us to manage expectations appropriately and better use eConsult within our arsenal of specialty care delivery. But I don't want to argue at this point, or maybe ever, for a specific benchmark or target.
Makes sense. And I know both you and Paul have had a great level of involvement. Go ahead, Paul. What were we going to say?
Yeah, well, I was going to say one of the other things that we have to think about when reporting is kind of an understanding of terms. People come to measures and they think they know what they mean. If you asked some people 10, 15 years ago, what does access to specialty care look like? In that context, they would have said, well, access to specialty care is when the patient is sitting in front of the specialist and the specialist is examining them. And in an eConsult world, access to specialty care begins with that turnaround time measure, right? Because the specialist is already engaging in the care. They're already evaluating the needs of the patient. They're gaining additional information via the conversation with the PCP, and they're actually engaging in decision-making, advice, initiating treatment in some ways. And so it turns over what you see as the way. What are you reporting on? When we report on access, we're reporting on when does the specialist begin to add value to the patient's care, and that begins with that turnaround time. But 15 years ago, you would have never defined access that way, and many systems around the country still don't define access that way. And then, of course, then there's the secondary measures of, well, when you do want to see them, how do you define that? And when is the right timeliness? And how do you measure that right timeliness? And so eConsult has challenged us to rethink some of the definitions of measures that we're reporting on.
Thanks, Paul. And with that, we're going to jump back. And you're right, Delphine. I was jumping between measurement and reporting and reimbursement, which I know we're talking a lot about these issues, which at times are relevant and at times we need to be very specific about about what we're talking about. So I want to step back for a minute and introduce our billing expert, who we look to for so many, for her wealth of information. So I'm going to let Robbie Franceschini from Blue Path Health introduce Carol, since she is such a helpful member of our work group. Go ahead, Robbie.
Great. Thank you, Libby, and good afternoon, everyone. We're excited to have Carol Yarborough here today. She's a business operations manager in telehealth at UCSF Health here in San Francisco, and is one of the eConsult Workgroup's real billing experts. So we're excited to have her. So Carol, maybe just to start us off, can you provide us with just a little bit of an introduction to your experience in billing for eConsults? Maybe how that's changed over the past couple of years.
Sure. I think the biggest change is now we can bill for it. So that's always nice. My direct experience at UCSF is I've recently implemented inpatient eConsult billing. We do have our outpatient billing, which is under our contracted payers and limited to several. But for inpatient, for San Francisco General, as well, I've been working with dermatology at the General and psychiatry. And so we've been doing eConsults in those two inpatient practices just for San Francisco Health Plan and Medi-Cal. So those are all the 99451s, which we know and love. And then certainly on the UCSF side, we have implemented the 99451 for Medi-Cal, managed Medi-Cal payers, and then the 99446 through 99449, and kind of set those up for our pediatric practices right now, since we're using like so many facilities, we're using eConsults as a way to transmit information from campus to campus and give credit to our physicians who are doing that internally as a curbside, perhaps, but also documentation of the actual information they're providing in the record. Now that we can go to billing that, it's taken on a little bit of a different flavor, and it has, well, I can say since I was speaking to Libby and Robbie last week, I did go and pursue my 99451 billing results at one of those two practices, and I'm happy to say that, yeah, payments come in. It's just amazing. So I never thought I'd see the day where there'd be actual money. So it did take kind of sequestering out from what we had, sort of like a smart referral service. So it was easy enough to do that on the inpatient side. So I didn't want to, get involved in any of the outpatient stuff that I know that Delphine and others have been involved with over at the General. And then certainly at UCSF, we have our well-established outpatient eConsult internal services as well. So the inpatient world just seemed a bit easier to start with for our practices. And it's been going well. I had a conversation with an ophthalmologist this morning that was like, I have about 100 of these to write up. I was like, okay, let me give your coders a heads up. That they're coming.
That's excellent to hear. And just as a reminder to everyone, please feel free to send in questions for Carol through the Q&A functionality at the bottom of your screen. She's here to answer your questions, so please send them along. But I think to get some of those questions going, Carol, one that is often top of mind is, what eConsult codes are covered. So specifically when it comes to, Medicare and Medi-Cal, what is covered when it comes to eConsult?
Sure. So let's start with Medi-Cal, because those are our nearest and dearest. The 99451 is covered. That is the one code that is covered for Medi-Cal, managed Medi-Cal. And that is the specialist response. So an order or a telephone call is placed in the system, and then then it goes into that area. So for Medicare, 99451 and 452, which is the primary care physician request for an eConsult, where they obtain consent from the patient and then submit the eConsult to the specialist and get that back. So that's covered by Medicare, as are the 99446 through 49, which are time-based codes and also have a verbal component to them. So in terms of the ophthalmologist I was referring to, she said, I spend so much time on the phone talking to the hospitalist, and it's verified in their record. And I said, yes. And now you have to write up your documentation about the question you were asked and then gave your voluminous response to. And she said, I'm going to be able to bill a lot of 99449s because these are Medicare patients. I'm like, you go. That's a big work RVU. So where there was nothing, there is now something. And what I like about the fact that she's billing, it is telling Medicare that we're using the codes, just please use the codes. That's all I ask. Yeah.
And Carol, what do you recommend, for people out there maybe who are in different states where their Medicaid program doesn't allow for billing free consults? What are helpful ways to maybe capture eConsults when you're coding if it's not billable to the payer?
It's not billable to the payer. There is also the virtual type of check-in that, it's not really a specialist code though, and it's not exactly what do I want to say? The guiding principle of CPT, the AMA CPT, is that you must bill the CPT code that is closest to the service you provide. And if you provide an eConsult, you must bill it and get it denied or not bill it at all. Or so if eConsults are not being covered in your state, I think you would just follow what we did up until 2 years ago, which was treat them as an internal way to take care of referrals. And get patients in under the 15-day guideline for the state.
And Carol, can I ask, I don't know much about the reimbursement policy area, but if there is no reimbursement for eConsults in a state, could they still put in those CPT codes and request it even if it gets denied? Part of that thinking advocacy, just showing that this is happening and more, and as volume goes up, perhaps that's an additional nudge in our arsenal? Or is that a no-no?
Well, that's what UCSF was doing for years with telehealth to the home as the originating site. We were submitting everything with a GY modifier stating we knew it was statutorily excluded. So we did submit them with a GY, because really what I wanted to get in there were the ICD-10 codes from when we go to quality reporting and HCC coding, so that we have all the patient's conditions in there. And so when we get our big bucket of money from the patients that are in those quality programs, that we did have their disease states covered for the amount of times we thought they'd be hospitalized or treated during the year. But certainly I'm not sure what we would bill to Medi-Cal if we did have a CPT code that wasn't covered. Like if we wanted to submit the 99452, there must be some kind of don't pay us code modifier. I have not looked into that, but I will. I'll get back to you on that and let you know.
Delphine raises a good point though, is sometimes it's good to be able to figure out how to capture this in a way that is quantifiable and ultimately is billable, even if billing is not available in your context or in your arrangements with whoever your plans are or whatever, is because sometimes the speed at which this is moving, it's good to be able to know how to do that. I think a lot of the systems that already had been targeting the prime metric that was raised earlier about non-face-to-face touches, all of a sudden in mid-March, we went America went heavily into non-face-to-face touches, and those systems that had built some foundation, some infrastructure with eConsult or video visits or whatever else they had pre-existing were able to move very rapidly into that. And so the billing space is no different. Learning how to capture this, how to quantify it, how to relate it to other interested parties, I think is really important. In the last couple of years here in California, we had a program called the Global Payment Program, and that was a program that used different kinds of clinical activity to satisfy certain qualifiers for the reimbursement that was available through that program. And eConsult was one of those satisfiers. And so it was a good run for us to be able to say, not how do we just throw this up on a report, but actually how do we capture it in such a specific enough way that we can share it with a payer for the purposes of reimbursement.
Yeah, that's something I actually mentioned to like our clinical social workers that aren't billing yet either. I'm like, okay, so we need more of you. Start billing, so we can go to leadership and say, look at all these encounters that we've billed out, and then the facility gets the money for it. So it's a good thing that I'll get more FTE because we've actually pulled in money. So yeah, reporting.
And Carol, and maybe we can start off with you, and Delphine and Paul, if you have thoughts too, please feel free to chime in. But what do you think are some of the key challenges that exist when it comes to eConsult billing and in really getting that going?
I think the thing that was I think, well, what held me up for the longest time was just doing it. It's like, and then I put a ticket into our IT team, and they set up all the orders for the pediatric folks. And then getting the information to our pediatric attendings and specialists saying, these orders are there waiting for you, use them. And like for infectious disease folks, I'm like, direct the hospitalist to go to that order and put in the order so that we've got something that'll trace it. It's going to set up an encounter for you that you can fill out with a correct, inpatient eConsult template and stuff like that. I think probably the hardest thing is implementation. And then certainly making your decision that you're going to keep it internal or external. Because if you go external, then there's all sorts of other considerations like contracting, who's going to bill. And that's one thing we don't think about a lot. Like I'll work with providers and they'll say, oh, great, we can bill these now. So I get a lot of phone calls from, Santa Clara. Like, yeah, I know, that's still free. But maybe we can think about a contract, if you can quantify how many free things you're doing, because you're not privileged at that campus. So if we can quantify how many times you're getting called, and we think it's, an easy enough lift, and often contracting is super easy. We've got our templates and privileging by proxy all set up. So, yeah. But the heaviest lift was actually just doing it, been kind of gung-ho to get that going in January, and then March occurred, and then we were all spinning on a dime figuring out what to bill and which place of service code to put on things and what CPT codes to use, and actually training people on how to do video visits. So that took up a bit of time, but this is the perfect time to start before before things get a little bit crazy again.
Yeah, I'll also add, I think where the data lie, I think is also just important to think about in terms of who can provide the data, right? For academic medical centers where e-consults are often, not always, but often embedded within the EHR, then I think it's easier for the centers to sort of bill, right? Because the data are right there. I think when you're using a specific vendor, that those data may not be readily available. And I think that's where a partnership with your health plan, as well as your vendor, can really be helpful as you're setting up contracting, so that you can get the data back and figure out who is going to then submit those data for eConsult reimbursement.
Excellent point. And one other question just came in regarding reimbursement. Carol, I think I'll put this one to you. So Wendy, who's in an FQHC environment, is wondering if she can build a 99451 and 99452 for a PCP to Medicare.
I don't think so yet.
So I think for, I'm sorry, go ahead, Carol.
Yeah, I wish I was an FQ expert. I want to say the eConsult fees are still in the daily fee that the FQ gets, that pays that primary care provider that is contracted with them. So again, it's about contracts and who the provider is, but it's all wrapped up in that fee, which is going to be a lot more money to the FQ than what you're going to get for an eConsult. I think that's the answer.
Mm-hmm. And Wendy, we'll make sure to send you
go back
to send you an email response with a more detailed response in there.
Yeah.
No worries. And another question came in privately for you, Delphine and Paul. Back to Prime and reporting, the question was, how can we promulgate the focus on the 2 Prime measures in payer programs?
I kind of referred to that earlier. I think really when you're thinking about turnaround time, speed at which a response is answered, and then the second one of what percentage of the care is been able to be delivered without a face-to-face visit. I think really it's helping locations see the value of those. And like I said, in COVID, that has become much more apparent. It's more intuitive to people. Parts of our system that I was always kind of struggling with, in late March and April were coming to me saying, hey, I remember talking with you about that, and we kind of did it, but we didn't really embrace it. How do we embrace it more fully or more effectively or more creatively? And so, I think those kind of things. I think also something that's really valuable is because those metrics don't have state or nationwide Medicaid or Medicare benchmarks. The program that led those, the Prime program, actually had fairly significant denominators, sizable amount of uptake of that. And so we're starting to establish some of the understanding of what could be an acceptable benchmark, what could be a standard that works. And I think that's something that will come out of using innovative measures in a program like that Medicaid waiver here in California. Because I believe it provides some of the impetus and the foundation for establishing benchmarks for innovative measures.
Excellent. And one more question that came in, Carol, for you is whether you have any experience billing Medicare Advantage for eConsult and any considerations there with, co-pays or collecting consent.
Just follow the Medicare guidelines. At UCSF, we did have, our contracting team is very proactive, and they did look at the different policies, and they do reimburse for eConsult. So again, just follow Medicare guidelines. You're going to do the same kind of billing as you would for Medicare Advantage. Often the Advantage plans add on more than Medicare does, so they're going to cover the basics of what Medicare does. So you're good there. Same guidelines.
Excellent. Great advice. Try, bill if you can, and worst case scenario, it'll get rejected. So great words of wisdom as always from you, Carol. And many thanks to you, Delphine and Paul as well, for sharing a little bit more about reporting with everyone during the session. So thank you all three of you for your time during lunch.